we are going to look at spinal and neuroaxial anesthesia. Some of very important things, that what conditions neuroaxial anesthesia is contraindicated. So the first and foremost important condition is if patient is not giving you consent, if patient is not willing, he is not agree for neuroaxial anesthesia, a doctor anesthesiologist must have to cancel that neuroaxial anesthesia. And if the patient has hypovolemia or low blood pressure, neuroaxial anesthesia is contraindicated because it can cause more worsening hypotension due to sympathetic blockade. So contraindications are there. And if there is coagulopathy, any platelet deficiency, any clotting factor deficiency, we do not have to do neuroaxial anesthesia. Or there is severe hypovolemia, elevated intracranial pressure and road traffic accidents, brain injury, intracranial hemorrhage can result into the contraindication, and no neuroaxial anesthesia should be performed. Or there any infection at the site of injection, and neuroaxial anesthesia is contraindicated. Site is L3 L4 at the first line, and this is the contraindication. So epidural versus spinal anesthesia, what is difference between that? Needle passes through ligament flavum, and there is sudden loss of resistance occurs and entered into the space of epidural space. So that is epidural. But if there is fluid coming out, that means we are in subarachnoid space. So we have to take care of that whether fluid is coming out or not. So if there is no fluid, we are in epidural space. If there is fluid coming out of the needle, that means we are in subarachnoid space. So this is the difference between uh, epidural and subarachnoid space. And epidural, we have to give continuous infusion rate, and we have to give large doses, and it can put into lumbar, thoracic and cervical level. And wider applications are there in single shot or continuous infusion spinal anesthesia. But if there is subarachnoid space spinal anesthesia, so it is only performed at L3 L4, not in lumbar or cervical region, because we are going into the subarachnoid space and fluid coming out. Only limited dose according to surgery and age and weight and build of the patient should be given. Large doses can cause toxicity, cardiotoxicity, because bupivacaine is most cardiotoxic drug. So it is not given in large doses, and only large doses given in epidural anesthesia. Now, clinical uses of neuroaxial anesthesia, like it is performed in surgeries like labor pain, C-section, delivery, pain management, any lower limb surgery, or any orthopedic lower limb surgery, any knee surgery, chronic pain management, orthopedic procedures. We perform neuroaxial anesthesia especially, and it is used in first 20th century. Initial report of permanent neurological injuries were there. In 1950 study, complications are rare with a skilled technique, asepsis, and safer local anesthetic drugs. And there are certain takeaways that it is contraindicated in certain conditions which we mentioned before. In epidural, there is loss of resistance. In peripheral CSF, we are in subarachnoid space. In epidural, there is slow, and spinal is fast. So dose is there in intrathecal toxicity, and in kids caudal blockage is done. So in this way, this is the simple information about spinal and neuroaxial anesthesia, that how we can perform that.